that refreshing break. Let's get back to our scientific sessions. The next session is about advanced assessment, and as chairpersons, I would like to invite Dr. Ajit Sawant, who is professor and head at LTMMC and LTMGH, Sion, Mumbai. Dr. M.A. Salam, who is the President, Urology and Transplant Foundation of Bangladesh. He's also the chairman of Department of Urology, Banga Bandhu Sheikh Mujib Medical University, Dhaka, and Dr. Kumar Prabhash, who is a professor and head of the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. I hand over the session to the chairpersons, and may I request the speakers. The first speaker, who is Dr. Abhishek Singh, that you have 9 minutes for your presentation. Sir, will you please be seated in the audience here, sir? Down only. Dr. Abhishek Singh is a consultant urologist at Multiply Patel Urological Hospital, Nadiad, Gujarat. He is going to talk about thromboembolic deterrence in urological cancer management. May I request you all to please put your mobile phones on silent mode. And Dr. Abhishek, you have 9 minutes for your talk and 6 minutes for discussion. Thank you.
A very good morning to the august audience. I am Dr. Abhishek Singh. I come from Multiply Patel Urological Hospital, Nadiad. I thank Sogo for this wonderful opportunity. I have 9 minutes and I'm short, so may not be visible. I'll talk about thromboembolic deterrence in urological cancer management. I have nothing to disclose. As we go along, I'll talk about the problem statement. How does cancer pathology impact this disease? Understanding the impact of anti-cancer treatment itself on VTE. How does surgery change what is the outcome? Using prophylaxis, what are the recommendations today and what are my take-home messages? Dilemma of a urologic oncological surgeon. In the same week, I deal with two patients, a 65-year-old gentleman, history of aortic valve replacement, smoker, and has a small renal mass, absolutely amiable to a partial nephrectomy. I do a partial nephrectomy, relay him on Clexane, and overlap it with warfarin. Post-op day 3, he has a massive bleed, hemoglobin drop of 3 grams. On the other side, I deal with a 65-year-old obese gentleman with a large renal mass with a renal vein thrombus. I do a lap radical nephrectomy, give no pharmacological prophylaxis. Patient goes home well, comes back with dyspnea, nearly collapsed, and has nearly a saddle embolus. My dilemmas keep on increasing, which is the way forward, and this talk gives me an opportunity to review everything I do. The incidence of thromboembolic events may be 4 to 7 times higher in this population that we are dealing with. When you anticoagulate them or give them prophylaxis, the risk of bleeding increases 2 times. Recurrence rate in these cancer patients of VTEs is extremely high. The treatment duration should be long, for about 4 weeks. When these diseases become metastatic, the risk increases further. It is more so in the first 6 months. When you talk about urologic cancers, bladder cancer is typically the one which is associated with very, very high incidence of VTEs, about 7.9 per 100 patient years, followed by renal malignancy. When these patients are subjected to chemotherapy and associated treatments, the incidence of VTE is about 11%. We give them supportive treatment in form of erythropoietin, colony-stimulating factors, and high doses of corticosteroids, which again increase the risk. As the patient have VTEs, their outcomes deteriorate. The risk of bleeding is increased. The patients who are actually diagnosed with a thromboembolic episode and then subsequently diagnosed to have cancer have a still worse prognosis. Surgery increases the risk by 2 to 3%, 2 to 3 times. Why does this happen? Let us go to the textbook of physiology. The tissue factor, which is required to convert a 7 into 7A, which activates actually factor 10 to take the extrinsic pathway along. This tissue factor is something which is really perpetuated in all the malignancies. Also, there are certain cytokines like cysteine proteinases which activate factor 10 independent of factor 7A. Cytokines like TNF alpha and interleukin 1 beta propitiate the action of tissue factors directly. VEGF causes angiogenesis, and fibrin, which is an end product of this, helps in angiogenesis and tumor propagation. Therefore, it is an extremely procoagulant state and leads to thrombosis. Direct cell-to-cell interaction with endothelium, leukocytes, and platelets is also partly responsible, along with the adhesion mechanisms that this disease brings in. If you look about look at DVT in RCC, the risk is about 4 to 36%, and it is caused by hypercoagulability, tumor compression, and venous invasion. Venous thrombosis itself causes a problem, and it causes obstruction leading to bland thrombosis. In CA prostate, the risk is about 0.5 to 40%. It is larger when androgen deprivation or related treatments are given. When you combine two treatments, the risk increases proportionately. CA bladder, the disease that we worry about the most. A cystectomy causes about a 7 times increase in the risk, and it may lead from 2 to 23%. Patients who are not undergoing cystectomy also have about a 14% risk. And most interestingly, the patients who undergo neoadjuvant chemotherapy have a substantially more increased risk as compared to the patients who do not undergo a neoadjuvant chemotherapy. Primarily, it is cisplatin which is responsible for this. So look at this data from the systemic review and meta-analysis of 8,000 patients, which included about 38 RCTs. The incidence was 2% when cisplatin-based chemotherapy was used. When the dose per week was more than 30 milligrams, it increased substantially. What about the newer immunotherapeutic agents? When you use ICIs, the risk of thromboembolism increases. And here the mechanism is slightly different. It is more inflammatory, and you can use certain markers like increased myeloid-derived suppressor cells, IL-8, VCAMs, and GM-CSF. So the risk would range between 24 to 40%. There is no substantial difference if you use a combination of IO versus only a single agent. Let's come to individual surgeries. Taking bladder first, if your patient is undergoing a TURBT, the risk is about 2.8%, and it may vary anywhere between 2 to 3%. So, but the problem is that you may not be able to anticoagulate these patients. Look at the patients undergoing radical cystectomy. Typically, an eyeball figure of 4% is the incidence of thromboembolism. In this particular segment of 1,700 patients, 70 had VT, out of which 17 had mortality. The risk factors were age, female gender, obesity, and thrombocytosis. Another data set where we get an important information that VT can occur after discharge up to 20 days. Therefore, a prophylaxis schedule of 4 weeks has been suggested. Here, the high-risk factors were BMI, surgical margins, type of diversion, and hospitalization duration. Now, according to the type of treatment also, the risk increases. It may increase if the disease is metastatic, if the patient is receiving forms of chemotherapy. This is the data that favors all us minimal access surgeons. The IROC study, which was meant to compare the basically the morbidity between the minimal access, that is the robotic diversions, and open diversions. Out of the other outcome measures, what was important and interesting and pertinent to my talk is that the rate of thromboembolic events was significantly high in the open surgery group as compared to the robotic cystectomy group at 30 days. Now, when you talk about prostatic malignancies, PLND is one thing that definitely increases the risk of thromboembolism to about 1 to 2%. But this data was not substantial. Therefore, this randomized control trial, it was a phase 4 RCT comparing men with RARP or RRP. Intervention was subcut heparin, which was 5,000 units every 8th hourly starting 2 hours prior to the procedure. Patients were observed for about 30 days, and they had an option of doing a duplex leg scan. About 50% of the patients were intermediate or high risk. 80% of them underwent PLND. Mean operative time was about 160 minutes, and they stayed in the hospital for an average of 1 day. What they found is that in the prophylaxis group, the number of events happening was less, but this was not statistically different. Meaning thereby that when the patients were given prophylaxis, the risk of VTEs did not decrease, but neither did the incidence of symptomatic lymphocytes, hematomas, or bleeding happened in the prophylaxis group. So that is an important bit of information. What is the real world practice? UK, they say that 98% of the patient receive prophylaxis, but in US it was only 17 to 18%. I think the data prevalence in our country is similar. If you look at radical prostatectomies, the coverage would be anywhere in 1 in 5. What about nephrectomy? Minimal access nephrectomy is a favorable factor. Open surgery, patient having preoperative dyspnea, diabetes, class 3 or 4, poor functional status, poor risk for VTEs. If you do a lymph node dissection, the risk significantly increases by about 2%. But the data in the nephrectomy settings is still controversial, as you can see from this particular slide. What happens in RPLD settings? These patients are relatively young, but the risk marginally increases. Depending upon the technique, minimal access gives a greater benefit as compared to open surgeries across the type of urological surgeries. Whenever you do pelvic lymph node dissection, the risk increases by 2 to 2.8% across all pelvic malignancies. If you risk stratify this patient depending upon age, BMI, and history of VTE into low, medium, and high risk, and take into account smoking, obesity, cancer incidence, and other risk factors mentioned, then you can risk stratify and accordingly give them prophylaxis. What are the agents that we have? We have direct.
Sir, will you please wind up?
Yeah. We have direct thrombin inhibitors, unfractionated heparin, low molecular heparin, and fondaxaparin. So basically, fragment clexin, that is deltaparin and enoxaparin, are commonly used in the dose of 0.4 and 0.2 ml per day respectively. You can use unfractionated heparin in the dose of 5,000 units daily, twice or thrice a day. So if you look at the general principle, what one should be doing, I'll just come to this particular slide. And if you look at the diseases, individual diseases, let's say radical cystectomy. The radical cystectomy in low, medium, and high risk across all groups, when it is done open way, it needs prophylaxis. In the robotic way, the data is unclear. If you look at radical prostatectomy for low, medium, and high risk, all three, if you are doing it in a minimal access way, then you may get away without giving prophylaxis. But when you are doing an extended lymph node dissection, open surgery, and a high risk open surgery, that is the position where you must give prophylaxis. Partial nephrectomy, radical nephrectomy, apart from very high risk patients, you can get away without giving a prophylaxis. And similarly is the situation for RPLNDs and lymph node dissections for CFNS. So I would conclude by saying that thromboembolic phenomena are a reality. Urological cancers, particularly bladder cancer, is an extremely high-risk disease. Thrombotic events need to be weighed against bleeding. Conventional heparin gives a maximum safety of reversibility. Subcute absorption may be erratic, so can be oral absorption because this patient may not be having correct meals. MIS fares better than open surgery. Lymph node dissection is a critically important risk factor. Risk stratification is the key step, and risk-adapted approach will give the best outcomes. Thank you for a patient listening.
Just 3 minutes for question and answers.
Hi, Abhishek.
Hello, sir.
You said actually if you give neoadjuvant chemotherapy, the risk of a thrombosis is actually increased in blood cancer patients. Would you recommend doing a DVT scan to do radical cystectomy in those cases? Because recently we have actually seen a couple of patients, those who have developed pulmonary embolism just on the day one of surgery. So when you talk about giving prophylaxis, you normally give after the surgery, you start giving prophylaxis. So if you give the prophylaxis on day one, because the patient had a pulmonary embolism in the day one itself, in the day one in the morning. So do you recommend doing also screening for all the patients, those who undergo radical cystectomy, DVT scan?
So based on the data, because the risk is 5% as compared to 5% without neoadjuvant, it is 23%. So screening ultrasound is a good idea, but using heparin on the day of surgery will be an extremely challenging thing to do. I think none of us surgeons are going to buy that.
So in that case, maybe it's a good idea actually to do a DVT scan, which is easy to do if the patient already has a thrombus. So in that case, you can decide regarding to maybe delay your surgery.
That is an extremely valid point, and we can, though it is not a part of a guideline recommendation, but we can try to incorporate that. I would agree, sir.
Yeah.
Last question.
Very nice.
Bit time hai yaar.
There was an observation earlier that if you give the low molecular weight heparin in any pelvic surgery patients or even transplant, there is increased chance of lymphocyte
Lymphocytes.
formation. Now, how do you correlate that with the lymph node dissection for penile cancer? Do you see that is there any study which suggests that there will be excess lymphoria or?
So, sir, we have per se this data from Tata Memorial both study basically a lot of work done in breast and axillary lymphoria. Even when I was a general surgery resident, this was a discussion done in this very hall that ligation versus no ligation versus heparin. This discussion, and it probably did not make a difference. The data that we have in level 1 evidence that we have out of my presentation is that the prevent radical prostatectomy trial, where the incidence of lymphocyte did not change with and without using conventional heparin, but it does not talk about low molecular weight heparin. Also, there was a discussion about the site of injection. If you gave it in the gluteal region, the incidence was slightly more for pelvic surgery as opposed to anterior abdominal wall or shoulder. So this is the information that I have.
Thank you, Dr. Abhishek Singh, for that excellent talk. We now have a panel discussion on prehabilitation for urological cancer patients, medical radiotherapy and surgical assessment. As a moderator, I would like to call upon Dr. Gagan Prakash, who is the Chief Division of Uro-Oncology and a Professor in the Department of Surgical Oncology at Tata Memorial Hospital, Mumbai. Dr. Vijay Patil, who is the medical oncologist on the panel, has not been able to make it. So may I request Dr. Kumar Prabhash to please take the role of panelist from chairperson, Dr. Kumar Prabhash. I also invite Dr. Sukhada Savarkar, who is an associate professor, Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital, Mumbai. Dr. Vivekanand, who is a consultant radiation oncologist at PD Hinduja Hospital and Research Center, Mumbai, to please come up. I request the panelists to be